All right, welcome everybody. Thanks for showing up, taking time out of your Saturday to come learn more about our program. We really appreciate your interest, and hopefully this will answer a lot of questions. And if you have anything else, we'd be happy to address them at the end. I'm Cody. I'm in the middle there on the right side. I'm joined today by my classmates Lucas Karlstrom and Megan Everson, as well as our assistant program director, Dr. David Daniels. Here's an outline of kind of what we'll cover today. I think the talk will probably take about 35 minutes. We'll introduce ourselves so you get to know us a little bit, talk a little bit about the Mayo Clinic, and then we'll start getting into the nuts and bolts of our program, how it's structured, what's important to us, how many cases we do, the diversity of pathology we see, and we'll talk about the call schedule, the campuses we cover, and end by talking about kind of what our life is like at Rochester and at Mayo before giving an outline of the upcoming lectures we have that are part of our virtual sub-by here. And there'll be plenty of time for questions at the end. So to save time, please keep track of your questions. If you have any questions that you want to punch in through the chat feature, by all means, and we'll get to them in time, okay? So I'll stop sharing my screen briefly. All right, so hi everyone. Like I said, I'm Cody. I'm one of the PGY5s here. I was born and raised in East Tennessee, outside a city called Chattanooga, which is about halfway between Nashville and Atlanta. I was born and raised there. I went to college and medical school at the University of Tennessee in Knoxville and Memphis. I did a research fellowship in the middle of medical school at the NIH and have an interest in pediatric neuro-oncology. So I'm in my 5th year here at Mayo. After my training, I plan to do a fellowship in pediatric neurosurgery and then have a hybrid practice where I specialize in taking out tumors and also run a laboratory. I see Megan, Lucas, and Dr. Daniels are on the line. Megan, would you like to introduce yourself?
Yeah, good morning, everybody. I'm Megan Everson, like Cody said, also one of the PGY5s. I'm kind of Midwestern through and through. So I grew up in Downers Grove, Illinois, which is about 20 miles west of the city of Chicago. And from there came actually pretty close to here, to a town called Northfield, Minnesota, to St. Olaf College up here in Minnesota. And then went back to the Chicago area for med school at Rush. And then, of course, came back here for residency. So my area of clinical interest is peripheral nerve. So I'm doing research this year with Dr. Spinner, and then also doing his fellowship enfolded as my 7th year. And then I'll be looking for a primarily peripheral nerve-based job after residency here. Lucas, do you want to go ahead?
Sure. I'm Lucas Karlstrom. I was born in San Antonio. My dad was an Air Force guy and kind of shuttled all over the country for a number of years. Went to undergrad at Iowa State, was actually going to be a veterinarian, got involved in research, and then matriculated into the MD PhD program at Mayo. And as they say, once you go Mayo, you never go back. So this is my 13th year now in Rochester. I've got kind of a varied interest, doing a little bit of some basic science this year, looking at radiation-induced injury, some regeneration, lymphatics, and senescence to throw out all the hot buzzwords these days. Some education, anatomy dissection, as well as clinical outcomes research, a few other things like that. I'll be a chief with Megan next year, and then I'm going to do the enfolded skull-based fellowship, and then I'm looking to do a post-grad endoscopic skull-based fellowship after that, and then hopefully get an academic job wherever someone will offer me one. That's all for me for now. I'll turn it over to Dave.
Okay, thanks everybody. Welcome everyone, I'm Dave Daniels. I'm one of the staff neurosurgeons here at Mayo Clinic. I guess we're starting all the way back at the beginning. So for me, that starts out in Minneapolis. I was born and raised in Minneapolis, Minnesota, so that's not too far from here. That's why I like the frigid Arctic cold and the beautiful summers that we have. I think we have 21 staff neurosurgeons here. There's 3 pediatric neurosurgeons. And so I kind of share a call with my 2 other partners for the pediatric side of things. I did my residency here at Mayo Clinic, so I spent 7 years doing that. And then I went to St. Jude Children's Hospital, where I kind of did a fellowship that specialized mostly in pediatric brain tumors. People ask me, what do I do, for a living? And I really have 3 jobs. And one of them is being the pediatric neurosurgeon, but I also have 2 other jobs. The 2 other jobs are education. So I'm the associate program director. So I oversee a lot of the aspects of the residency program. But I'm also on the MD PhD executive committee. and our pharmacology and graduate school executive committee. And so from an education standpoint, I spend actually quite a large percentage of my time working with various students at multitude of levels, all the way from high school through college, med school, and residency. And so that's something that takes a good deal of time. The last is to run a lab. And as Cody was introducing himself, I was like, oh, that sounds familiar. Interested in pediatric neuro-oncology, interested in running a basic science lab. So that's what I do. I have a 50% FTE in research. And so I spend a good deal of my time in the laboratory. Now, the 50% time in research is kind of on paper. I can say that the clinical aspects of the job kind of always are there. And I don't think a day goes by that I'm not reviewing 2 or 3 scans. Cody's probably sick and tired of me sending him emails of just clinic numbers. Just review the scan, tell me what you think. Review the scan, tell me what you think. But we have a pretty robust practice. My practice is pretty niche-y, meaning that I really do pediatric brain tumors. And that's what I study in the lab, and that's what I do in the operating room. Yes, I do other things. I take call and whatever else comes in, I do. But we've kind of spread up our practice in such a way that allows me really to focus on that. I guess fun facts about me. I'm an obligatory exerciser. I have to work out every day. My wife tells me it's actually unhealthy, apparently, to work out every day, but I say to the contrary, I need the endorphins. So I'm usually up at 5 o'clock in the morning, drinking my Red Bull and coffee to get me through my workout. I ride bikes, I lift weights, and I also have a family. I got 3 kids and a great wife. Spend a lot of time with them. I am not a firm believer in work-life balance because I don't think work-life balance exists. What I'm a firm believer in is work-life integration. And so I'm constantly finding ways to integrate my family with work. That means that my kids may go to meetings with me and you know, we have fun time, you know, in the evenings, but then during the day I'm doing something with work, or my kids are rounding with me. My kids have spent many Saturdays sitting at the hospital, coloring and playing on the computer and other things while dad's in the operating room, for better, for worse. So anyway, that's a little bit about me. Time to turn it over to Cody and the rest of the group here to kind of go over the program in a greater detail. You're on mute, Cody.
All right, everybody can hear me now? I'll start sharing my screen again here. There we are. More better. All right, so here's an exceptionally cheesy, but also very accurate slide, courtesy of our program director, Dr. Van Gumpel. It's a little bit outdated, but I think it does a pretty good job of kind of summarizing where we're from. We're really from all over the map, as you probably gathered from our introductions. We have folks from the East Coast, West Coast, South, Mid-South, Midwest, as well as from across the world. I don't think it's fair to say that we have most time zones represented, but we're pretty close. So where is Mayo? People hear that we're in Minnesota and they think that we're, you know, up here close to Lake Superior or at International Falls or someplace. Chances are we are closer to Canada than you, but we're not as close as most people think. Rochester is down here, kind of in the boot of Minnesota, about an hour away from Iowa and Wisconsin. Roughly the same latitude as around Portland and Boston, but of course we don't exist on the coast. We exist close to the Great Plains, and why is that? If you've been to Mayo or you know anyone who works at Mayo, we take our history very seriously. How did we end up in Rochester? And the story of Mayo Clinic starts in 1883. A tornado destroyed the town that was Rochester, and a relief effort was organized by William W. Mayo and Mother Alfred Mose of the Sisters of St. Francis, which was a teaching order in town. And after the dust settled and people started to rebuild, Mother Alfred proposed that they build a hospital with the teaching order's funds, but only on the condition that Dr. Mayo and his 2 sons, who are the famous Will and Charlie, would provide medical care as part of the hospital. They agreed on a handshake, and that's how St. Mary's Hospital came into being. This picture down at the bottom is St. Mary's Hospital in 1910 at the same site where it sits today. Throughout the 1890s, the 1900s, the 1910s, the Mayo brothers became internationally renowned surgeons, hosted people from all over the world, and traveled a lot themselves to learn the most advanced surgical and anesthetic techniques that they would bring back to Rochester, and therefore created one of the world's leading practices in medicine and surgery, and they're known for such innovations as pioneering the first group practice model, which is the foundation for how we practice medicine today, as well as having the first integrated medical system, which is courtesy of Dr. Henry Plummer, who you'll hear about if you ever have the chance to come visit us. We have a very long history of neurosurgery at Mayo. It stretches all the way back to Dr. Charlie Mayo. Some other famous neurosurgeons that you may or may not have heard of who either trained here or worked here include Alfred Adson. You ask for an Adson-Beckman retractor or an Adson pickup. That's this gentleman here. He was one of the first neurosurgeons to treat glossopharyngeal neuralgia, as well as a lot of autonomic nervous system disorders. Colin McCarty, you may not have heard of before, but if you're in skull-based surgery, he is a major figure in the history of that field. When you learn to do orbital-zygomatic craniotomies, you make a McCarty keyhole, which exposes the periorbita as well as the anterior middle fossa, and that's named after this gentleman here. Everyone will notice the gentleman on the bottom right, Al Roten. Most people know him for his time at the University of Florida, where he did most of his work with anatomy. But his first staff job was actually at Mayo. He worked here for some time before taking the chairmanship at the University of Florida.
Hey, Cody, I was just going to interject on that. Al Roten came as a visiting professor about a decade ago, and this was really funny because he started out his talk and he had some slides of Mayo Clinic at that time. But he said he originally planned on spending his career in Minnesota at Mayo Clinic. And he said the very first night after they moved in, they got 2 feet of snow. And he said that he opened his garage door and he said at that moment he realized he was not going to stay at Mayo Clinic. So moved to Florida and the rest is history, as they say.
Yeah. But we do get a little snow occasionally, for those of you who don't know. On the far right side is Thor Sundt. He is a giant in the history of cerebrovascular surgery and really pioneered a lot of techniques for treating complex intracranial aneurysms as well as cerebrovascular bypass for atherosclerotic disease. So all that to say, we have a long history, a good pedigree of neurosurgery at Mayo, and we're very proud to be part of that. So Mayo has obviously, on the outside anyway, changed a lot in the last 110 years. In addition to the campus in Rochester, we have campuses in Jacksonville, Florida, as well as Scottsdale, Arizona. In Mayo Rochester specifically, we have our own network of hospitals collectively known as the Mayo Clinic Health System. These serve as independently functioning entities in the community where a lot of simple spine and cranial surgery get done, and they serve as a referral network by which complex cases get referred into Mayo Clinic Rochester. So most hospitals have a complex referral network of community hospitals that's very unique to them, and ours has been formalized into the Mayo Clinic Health System. So we'll start getting into kind of what's important to us and what are we looking for in a potential resident, because most of the people on the call will be applying for residency either this year or at some point in the near future. Well, one of our favorite quotes at Mayo is from William J. Mayo, who is the junior William Mayo. And at a commencement address he gave at Rush Medical College, he said, "The best interest of the patient is the only interest to be considered. And in order that the sick may have the benefit of advancing knowledge, union of forces is necessary." And this is kind of pasted on everything from the walls to the computer backgrounds here. And it's often kind of taken out of context as a way to say, you know, teamwork makes the dream work or some trope like that. But the bottom line is that the needs of the patient come first. And even though people say that a lot here, it is something that we definitely take to heart. And we're looking for people who believe the same thing. So what does that mean? It means that we're looking for compassionate, driven people who genuinely want to help people get better and to help healthy people stay that way. From a neurosurgical standpoint, we're looking for future leaders in their fields. As you can tell from meeting just the PGY5s, and as you'll learn, kind of learning some more about the residents both today and throughout the virtual sub-I, we have very different fields of interest, but what's very important to us is that we're selecting people who want to be the best at what they do. This requires a lot of autonomy, of course, but we certainly don't sacrifice that at the expense of having someone who is a strong team player. We need someone who thrives on having that autonomy, that kind of freedom to pursue what they know they need to do to succeed in their field, but who recognize that in order to provide good patient care, you're a member of a team, and that you integrate a lot. It takes integrating a lot of people into a big team to provide the best patient care that there is to offer. So how we train is a little bit different from the traditional academic neurosurgery setup. In most neurosurgery training programs, the setup is such that there is,
she's stretching.
Stop here for a moment. There we are. So the way we train here is a little different from probably what you're used to at other institutions. If you come to visit us, or if you've spoken with any residents in the program, we train according to the mentorship model. And what that means in terms of plain language is that you serve as an apprentice to the staff during junior residency. So in PGY3 and PGY4 especially, and also part of PGY2 later on in the year, each junior resident is assigned to 2 staff services that operate on alternating days or alternating weeks in 2 to 3 month blocks. And in this model, the junior resident will act as an apprentice to the staff. And this isn't just in the operating room. Not only are you first assistant in the operating room, but you're placing orders for that patient before the surgery, and you're managing that patient's care after surgery all the way up through discharge. Oftentimes, if there is a question about routine patient care after the patient's discharge, the nurse will often contact you and say, what do you want us to do about this? So the end result of this is that we work with the same team day in and day out. This is not only the staff, but also his or her nurse, the technicians in the operating room, our scrub assistants, the OR nurses. That team is the same on each of those operating days. So we get to know each other very well. As a sole resident on each service, the staff learn to trust you very early on in residency. Oftentimes, it's kind of difficult for the staff to get to know the residents in a traditional academic model because they don't know who's going to be assigned to their operating room each day, and it's kind of just a matter of happenstance, kind of who gets to know who in the program. But in the mentorship model, we ensure that by the end of PGY4, every resident has worked extensively with every staff, and that everyone is comfortable with that person advancing to chief residency so that they can make decisions on their own about cases. Caseload. On average, we have about 8 to 13 first starts each day. It's been a little busier than that recently, and this is just at St. Mary's Hospital. So this is our the major campus where we work, and this is not including 1, sometimes 2 first starts at the Gonda building where we do a lot of outpatient procedures. Last year, we did 5,002 surgeries at St. Mary's Hospital and in the Gonda building, and this does not include endovascular procedures, gamma knife radiosurgery, or bedside procedures. These are cases that are done open in the operating room. All inpatient endovascular and radiosurgery procedures are done at St. Mary's Hospital, so at one campus. St. Mary's Hospital has over 1,200 beds, including almost 150 beds as part of a dedicated pediatric hospital. 67 operating rooms and 2 dedicated neuroendovascular suites. As I mentioned, we do some outpatient procedures at the Gonda building, which is in downtown Rochester, and we do some at St. Mary's Hospital as well. Occasionally, we'll go to the other hospital in town associated with Mayo, Rochester Methodist Hospital, for our fetal myelo repairs, but we don't do any inpatient procedures other than those at RMH. So this is St. Mary's Hospital. A few slides back, I showed you kind of what it looked like in 1910, and this is it 110 years later at the same site where it stood before. Obviously, it's much bigger, but certainly no less beautiful. This is our home base. This is where we spend 95 to 98% of our residency. So in addition to St. Mary's Hospital, I mentioned Rochester Methodist Hospital, or RMH. That's that hospital in the middle there, close to the clinic buildings. RMH has 51 dedicated ORs of their own. In addition to the fetal myelo repairs, sometimes we'll do complex peripheral nerve procedures there with Dr. Spinner. And the Gonda building has 10 dedicated operating rooms for outpatient procedures, such as outpatient peripheral nerve procedures, battery changes, that sort of thing. Whenever I was interviewing, I always found it interesting to see how training programs presented the conundrum of having to cover multiple campuses at once. It often divides up the resident cohort and makes it difficult for residents to get to know each other. The commuting is often a hassle, but that's really not the case here. So in the bottom left is a map of downtown Rochester. Here is St. Mary's Hospital, and it's about 3/4 of a mile away from downtown. The clinic building is here where the person is walking, and just adjacent to that is RMH, the other major hospital in town. This is about a 15 to 20-minute walk. There's a shuttle that goes between the campuses every 10 to 15 minutes. If for whatever reason you do have to go downtown for a procedure or to see a consult, it's a trivial task. So our program structure, we now take 4 residents per year. This was increased from 3 residents per year 2 years ago. And this is the breakdown by post-grad year. Your intern year, you spend 6 months on a clinical neurosurgery service. This includes 5 months as an intern on the chief service, which I'll get to briefly. The later months of being an intern on chief service means that you are the junior resident on that service. You're the dedicated junior working with that chief resident. And the 6 months also includes 1 month on Dr. Meyer's and Dr. Van Gumpel's service. Dr. Meyer does some brain tumors. He does cerebrovascular, carotid endarterectomies, has a nice general cranial neurosurgical practice. And Dr. Van Gumpel does a lot of skull-based surgery, endoscopic pituitary surgery, meningiomas, schwannomas, as well as some epilepsy. So you spend a month on those services during your intern year, really learning to cut your teeth on basic craniotomies, endoscopy. That way, whenever you come back on staff service as a PGY2, you are very well prepared to play an active part in those procedures. The rest of PGY1 is spent with other services in the hospital, such as neurocritical care, the neuroendovascular team, getting your endovascular numbers and learning how to get access and thread a catheter, as well as with neuroanesthesia and in the surgical ICU. By the end of your intern year, all of your non-neurosurgical requirements are met. So PGY2 through 7 are dedicated to being a neurosurgery resident. Starting PGY2, you'll spend 9 months as a junior resident on the chief service and at least 3 months as a junior resident on a staff service. The chief service, well, I'll talk about that more shortly. So starting as a late PGY2, you're already kind of being integrated into the mentorship model. The staff are starting to know you as the resident who is running their service and participating in their cases. PGY 3 through 4 are dedicated to being a resident on the staff services. These include the gamut of neurosurgical procedures, neuro-oncology, cerebrovascular, skull base, spine in all its forms, including spine onc, doing complex peripheral nerve, as well as pediatrics. PGY 5 through 7 are dedicated for elective time, chief year, and for those who are interested in enfolded fellowship, one of these years can be dedicated to that. So here's just an example. Here is my PGY3 schedule. I started out PGY3 year in July on the pediatric neurosurgery service with Dr. Daniels and Dr. Ahn, learning the basics of pediatric neurosurgery. Dr. Daniels and I took out a lot of tumors together. After that, October through December, I was the junior resident on Dr. Van Gumpel and Dr. Meyer's service, doing a lot of endoscopic pituitary work, posterior fossa surgery, taking out gliomas with Dr. Meyer, doing some aneurysms and AVMs with him. And after that, I moved on to spend 3 months with the spine service and ended that with what we call the quad service here, which is our interaxial brain tumor service, taking out a lot of gliomas, occasionally some meningiomas, and learning how to do microvascular decompressions with Dr. Pollack. So chief year. This is, in addition to the mentorship model, the real gem of our program and something that really sets us apart from others. Chief residents at Mayo run a service on their own with a mix of cases from both inpatient and outpatient referral systems, as well as taking care of the trauma that comes into the hospital. So they have their own clinic downtown. At least 1 to 2 days a week, they have clinic days where they see consultations from staff outside of the hospital, as well as referrals from throughout the health system. And this clinic runs independently. You have a dedicated nurse, you have your own scheduling team, and you have ancillary staff that will help refer them to any diagnostic procedures that they may require prior to considering surgical intervention. The chief service accepts all inpatient consultations at St. Mary's and Rochester Methodist hospitals. Now, if these are urgent, of course, they have to go to the OR immediately. There is a staff on call at all times with whom you can staff these cases. But if it's not urgent, you can treat it as an elective case, and these cases are staffed at the chief's discretion. You get to choose with whom you want to do this case. As an inpatient service, the chief service is autonomous. It has its own junior resident as well as the chief, and this is a PGY2 or PGY1, as well as a team of very experienced PAs and nurse practitioners who really make the service run smoothly. The end result of this is that the chief runs the equivalent of his or her own practice, similar to what most junior staff experience at other hospitals, except that we get to do it in a very safe setting within the confines of the training program. So taking a step back, looking at senior residency as a whole, there is a lot of flexibility. As you heard myself, Megan, and Lucas early on kind of describe what we're planning to do with our elective time. We're choosing 3 very different paths, and the program is designed to accommodate a wide range of interests in its residents. PGY5 is almost universally spent doing research in any form, with some exceptions. We do have some degree granting paths. We offer a formal path to get a Master's of Public Health through the Clinical Investigator Training Program, which is 1 year. We also have a dedicated PhD track, which is 3 years of training, PGY5 through 7. And if you choose this track, you actually come back as a chief in your PGY8 year. Some residents spend this time in the wet lab, some do clinical research, and some residents have spent this time doing an external fellowship where they physically leave Rochester and they go somewhere else to do something that they could not do here in town. And I'll get to some specific examples here shortly. PGY6, you can spend either continuing doing research if you have a big research endeavor that that you need 2 years to complete, or you can come back and do your chief year. If you do your chief year as PGY6, this allows you to do an enfolded fellowship during your PGY7 year, or if you're doing 2 years of research during 5 and 6, you can come back and do your chief year as a PGY7. There are lots of different ways that you can mix the pieces of this puzzle together. Here's some other specific examples in addition to our own. These are all PGY 6s, 7s, or in Ben's case, 8s, and how they've kind of taken advantage of the flexibility that was offered to them in the program. On the far left is Des Brown, so he's one of our current chief residents. He actually elected to start out his senior residency with an enfolded neuro-oncology fellowship with Dr. Burns and Dr. Parney. After that, he did a visiting fellowship with Dr. Defoe in Paris and came back and did, I believe, 9 to 10 months of work in the wet lab with Dr. Parney. And now he came back and he is one of our chief residents running his service. Chris Graffio, who some of you have met through his skull-based talks, he spent PGY5 obtaining an MPH in biostatistics, came back, did his chief year, and now he is starting his skull-based fellowship. Ben Himes, who is now Ben Himes, MD, PhD, recently defended his thesis and obtained his PhD in neuroimmunology, and he is now starting his chief year as a PGY8. On the far right is Brandon McCutcheon, who is now a PGY6. He is starting his second of 2 years in an external fellowship in Palo Alto. They're doing a fellowship in biotechnology development. He'll come back next year and be a chief. So the real nuts and bolts of the program, the call schedule. I would say the call here is probably not as bad as what you're used to seeing. Day call is covered by a team of our experienced NPs and PAs. These are the physician extenders who help cover the chief service. They will cover day call. And for nights, there is one junior resident in-house. Like I said, almost all the pathology is at one campus, so we really only require one resident to be taking call at any given time. And there is one senior resident, a PGY 5 through 7, who acts as the on-call chief. Weekends, there's one PGY 2 who covers the chief services, and there are 2 other junior residents who cover the staff services. This system has one person working on days, one on nights, and they split the staff services so that the rounding burden isn't too bad. And lastly, there's one senior resident of 5 through 7 who acts as the weekend chief, who kind of accepts all consults for the weekend and answers any questions the junior residents might have. During PGY 1 year, you typically spend about 3 to 5 buddy calls or early on your neurosurgery rotations with the MPs and PAs to kind of learn the lay of the land, where things are, where do you go in the ED to see someone. If you have a question about something, who should you contact? And then by the end of your neurosurgery rotations in PGY 1, you're comfortable starting to take call on your own. So we'll ask our first years to take 2 to 3 in-house night calls toward the end of their neurosurgery rotations. For junior residency, the time when you are first call, when you're in-house, that is roughly about Q10 to Q14, depending on seniority. PGY2s take a little bit more call than the PGY4s, but it's not that frequent. And a PGY 5 through 7 will act as a chief on call Q7 to Q14, depending on chief duties. Because the current chiefs are actually the residents who are catching these patients on their service, they will actually take more call than the PGY 5s and 6s. So I'll end with just a couple of comments about perks of being a resident at Mayo generally and in the neurosurgery program specifically, as well as what it's like to live in Rochester. We have 15 dedicated vacation days per academic year, and this does not include holidays, weekends, trips, that sort of thing. These are dedicated holidays that you wouldn't have, or dedicated vacation days that you wouldn't have otherwise, as well as 10 dedicated trip days per academic year. If you have a poster or a talk accepted to a conference, there is a stipend that will cover conference registration. Creating a poster, having someone illustrate something for you, there is a stipend for that. And there's an additional stipend for travel, lodging, food, local transportation, anything you need to live in that city for a few days while you're presenting your research. It's extremely rare that one of us has to kind of take money out of our own pocket in order to present our research at a conference. The Mayo generally, and the department specifically, really goes out of their way to make sure that we don't have to work to present the fruits of our labor. For new moms and dads, you have 6 weeks of maternity leave as well as 6 weeks of FMLA, and something unique to our program, there is a dedicated policy for paternity leave. You have 5 days off as a new dad, which I personally found to be not as long as I really wanted it to be, but it's much better than the absence of a paternity leave policy, which is what I found to be more common than not when I was interviewing at other programs. We have some very experienced EPCs. These are our program coordinators. If you've had any correspondence with the program previously, you know Katie Millard and Corey Scogan. They basically grease the skids and keep the sludge moving in our program. If you have any questions about the nuts and bolts of our program, they are excellent people to ask, and they're the ones who really keep things moving on a day-to-day basis. Of course, we have a meal stipend. Well, I say of course. I learned in my interview time that this is not a universal feature of training programs, but there is a meal stipend so that you don't have to pay for your own meals if you're taking call in the hospital. We have 2 gyms on campus. The first is the Dan Abraham Healthy Living Center, and this is close to downtown Rochester, about a 10-minute walk from the hospital. And there's also another gym that is in St. Mary's Hospital, where we spend most of our time. So if you're trying to get in a workout or a run before you're scheduled to take in-house call that night, you can go downstairs and knock that out before you start answering pages. There's also a Peloton, which our department has purchased for us. Dr. Krause has been trying to get me to spend more time on that. And if for whatever reason he goes back and watches this, I did use it this morning. I got off it right before I hopped on this call. So perks of living in Rochester. Rochester is actually a really easy place to live. I think probably the best word I can come up with to describe what it's like to live in Rochester is accessibility. It's really trivial to commute anywhere in the city. You're not going to be stuck in traffic jams. Your commute to work is 5-10 minutes at most, and you're never more than 10 or 15 minutes away from most things that you want to do in life. We do actually have an airport here in town. It is strictly speaking international, but the benefit of having an airport here is that we have direct flights to most of the major commuting hubs for air travel, such as Minneapolis, Chicago, Detroit, Denver, Atlanta. You can get flights to all those places directly from here out of town. If you want to go to Minneapolis and you know, enjoy the amenities Minneapolis and St. Paul have to offer, it's only 70 minutes away, and that airport obviously is a Delta hub, and you can get direct flights to most places out of there. The cost of living in Rochester is very low compared to what most of us are used to. So most of us are able to own homes, which is a really nice perk. It's also very safe, family friendly, and you have access to a lot of outdoor activities. And the program makes sure that you have plenty of time to take advantage of it. You know, I'm a huge mountain biking fan. I'm not very good at it, but I like road biking. There are lots of places that are safe to ride on around here. Lots of hiking trails. If you want to take your family to the zoo, we have a lot of parks in the zoo. And there's plenty of stuff to do outside when the weather is nice. So I'll kind of wrap up with a summary of things to come in the virtual sub-I. As you all know, we have a series of talks on a lot of different topics. We can use this as an opportunity to let you get to know the residents. We'll have both residents and staff give talks. If you're planning on coming, please RSVP so that we can get an accurate head count. And if you have any questions from any of these folks, please don't hesitate to reach out by email. All right, thanks everyone for listening. That kind of sums up our program, what we're about, and kind of how we're structured. Be happy to take any questions. I think you should all have the ability to unmute yourselves if you like, or if you want to ask features through the chat box, by all means.
Hi, I have a quick question. I know that for some of us who are supposed to do the sub-I at the Mayo Clinic, we're supposed to give like a quick talk on a Wednesday or something. Is that, I haven't got any more information about it. I think the first one was supposed to be this week. I'm not too sure if you heard anything about that.
Yeah, the first one is scheduled to be next week. We're still waiting on a couple of folks to get back to us regarding date preferences.
Okay.
So we'll reach out to you this week once we get those couple of stragglers in the schedule.
Okay, sounds good. Thanks.
I have a question. How do you guys find like the kind of mentorship and guidance for your research interest? Like, you know, what kind of, I guess, you know, guidance and work do you do with the faculty to sort of identify your interests and identify projects that might be worth working on, especially things like basic science?
Let me start with that. I can say from the staff standpoint, everybody that comes in is assigned a mentor as one of the staffs early on. Whether that pairs with their interest, that really doesn't matter per se. That's just this kind of start of mentorship. But as the residents start to hone in on what they are interested in, what their likes are, then we kind of move people around, you know, to accommodate that. So Cody has been somebody that I've been mentoring from very early on. He was actually in Memphis while I was in Memphis doing my fellowship. And so, you know, that was easy for us to kind of pair together early on. And, you know, like Lucas has an interest in skull base, but also has an interest in research. And so he has a kind of a primary skull base mentor, but he also has a couple of research mentors. And so I think it's just really kind of finding people's interests and then pairing them up with the appropriate staff that can provide that mentorship. We expect that all the staff will be mentors, and I can say that you know, we have the gamut from, you know, first year staff all the way up, you know, through, you know, people that are about ready to retire. But I can say everybody's very willing, you know, to help out with that regards, because education is one of the you know, our primary things that we take very seriously here. You know, the major talk here is, you know, first, the needs of the patient come first. So that's the clinical practice. And that really does drive the majority of the show. But the next thing is the fact that we call it three shielded. The Mayo brothers kind of came up with this original idea, and it's obviously not novel, but it's the fact that clinical practice, research, and education are really kind of the foundation for medical type training. And I can say that that's what we really value here. And so we really try to, you know, emphasize that and again, get people into the right people to see that. We recognize that not everybody wants to go into academic neurosurgery. And so I think as staff, we've sat down and try to highlight, you know, what are our goals in training residents? And the primary goal is to train good surgical residents that are going to become good neurosurgeons. That's obviously the primary goal for neurosurgery. Closely tied with that, we do want to train academic leaders, but we fully recognize that the field would be saturated if everybody came on and was an academic leader. So I think what we're looking for is to train a mix, probably a 50-50 mix of academic people and private practice. And so I think that's a good mix for us to shoot for. And I can say that, we have historically kind of along those numbers. And again, if somebody is interested in private practice, then a lot of that is spine, and a lot of those folks spend a lot of time with our spine people. And we have other opportunities to go into the kind of Mayo Clinic health system. We've had numerous of our residents go on to get positions within our health systems and do essentially private practice spine, private practice X, Y, or Z. But we have those opportunities in some of the surrounding communities for some of those residents who are interested in that pathway to explore that. Hopefully that's one of the chief residents calling me about a case, which I told him to call me in another 15 minutes, but I guess we're jumping the gun there. So I hope that answers your questions. Did Cody, Megan, Lucas, did you have anything to chime in, I guess, going through this and how you kind of got paired up with folks?
Yeah, I think that's quite well summarized. The only other thing I'll add is we don't have any formal rules about having mentors within the Department of Neurosurgery. Of course, it's a good idea to have a neurosurgery mentor, certainly from a clinical aspect. But I have a couple people that I work with quite closely from neuroradiology, from bioengineering, from immunology, and a few of the other departments. So there's a lot of integration between both on the clinical and research side between departments, and you're certainly allowed to have mentors that cross a variety of interests and expertise. And I think from my standpoint, as someone who Dave mentioned has a couple of different mentors, it's nice because you can have a very balanced approach and you can utilize strengths and expertise that people may have and can leverage, your interest to culminate in what you want to do. And so you're certainly encouraged to find interest both within and outside the neurosurgery department.
From a staff standpoint too, I should point out that we have to document our mentors and then the dates and times that we spend with our mentees. I think that's obviously things have changed where, ACGME, those people come around looking. And so those are one of the things that we do. But I can say that, so we sort of have a formalized process to do it, but I can say that I more the informal stuff. I literally just will randomly text Lucas and say, hey, you got time for a coffee right now? Because I want to get caught up on where you're at with the research stuff. And so I think that most of the stuff that I do is on the informal side, but it is also formalized. Megan, Cody, do you have anything to add?
Yeah, I would add that, while we of course have the staff surgeon mentors who help us get plugged into research, we also have kind of an army of people here who are set up to really help facilitate research. So whether that's research coordinators or research associates, research fellows, there's a whole group of people who are kind of plugged into making the research happen and kind of facilitating things and getting moved along with projects and helping in that regard as well.
Yeah, as Dave mentioned, and I think I mentioned previously, I'll be doing 2 years of research, and I'm actually working with atypical teratoid rhabdoid tumor, which is a genetically and epigenetically very unique tumor of very young children. So, Dave is obviously my clinical mentor, and I have a lot in common. My path has a lot in common with his. But in terms of kind of the nuts and bolts of my research, I have several mentors in basic and translational science that I consult on a regular basis. One of my kind of informal mentors now is actually in the Department of Gastroenterology. We have a very wide network of people who are not only available to speak to you about specific research questions, but Mayo, as with most places in the Midwest, is a very welcoming place. I have not found anyone who's not willing to sit down with me, discuss ideas, and talk about the nuts and bolts of how to make my research happen. It's a very easy place to kind of find where you fit in. Any other questions folks wanted to ask?
Hey,
sorry.
Mayor. Sorry. Thank you. Thank you, Dr. Daniels, and thanks, Carl, for presenting all of this. I'm George Maragos. I work as a pre-residence fellow in Manhattan in Mount Sinai Hospital. I just wanted to ask a bit more about who sees the consults during a typical day, and how the night float is with the resident that is on call.
Sure. So during the day, as I mentioned, we'll have a team of PAs and NPs who are, part of the chief service who is catching the consult. They'll be the first person to go see the person, get an exam, get an accurate history, and they will pass that up to the chief resident. The chief resident will kind of help make a decision about what to do next, and if it's emergent, they'll take the person to the operating room. We don't have a night float system. It's divided up to where an individual will take call every 10 to 14 days. And the day after you take call, you will be post-call, so you can recuperate, and then you come back and you cover your services the day after that. As part of the handoff process, which I think is what you're getting at, the night person will be in touch with the catching service, so the chief service that's going to manage this patient, both in person and by email that morning. All of our offices are physically located right next to each other in St. Mary's Hospital, so it makes communication very fluid between teams. Unlike a lot of other places, we don't have like big bulky lists that have long lists of to-do items. Because we have such fluid interpersonal interaction, it's very easy to communicate the plan between different teams or with the day team. Does that answer your question?
Well, so Cody, I was going to add the fact is, like, during the day, this is the chief team that's going to go see that patient. So the ER is really covered by our physician assistants. So the residents are in the operating room. By and large, they may be in between cases, but the onus is on the physician assistants to see most of those consults. Any staff consult that's either in the ER or on the floor. So those are like acute consults. The regular consults that might be, oh, this patient came in yesterday and now we want to have neurosurgery see them. Those are put in as regular consults, and those regular consults then are seen by those chief teams. And typically in the past, if you have one, 2 or 3 chief services, it's just they sign up for, ABC, ABC, ABC. So that part is kind of the luck of the draw. I can say when I was in our program, there was 2 chief residents. I was interested in complex cranial stuff. My partner was interested in spine stuff. So we didn't really pay attention to A, B, A, B, A, B. We just, spine went to him. Cranial stuff went to me. But again, you can kind of make it up, how you want to do it yourself. But that's how the regular consults are done. So those are generally seen by the junior resident on the chief service, which is either a PGY1 or PGY2 at their convenience. Those, usually, during the day, those are, you get done with your work day, then you go, as far as the operating, and then you go see those consults, and then they get staffed with the chief. But as you keep hearing, there's a chief that's running these services. So we really have a PGY 6 or 7 that's responsible for all of this, managing all of this, and then they seek out the staff to either run it by them or to get further help. We've talked many times about having our PGY. So originally, neurosurgery allowed for a PGY 6 to graduate at that level, and then most programs were still 7 years. During that rubric, we tried to actually graduate our students at the end of the 6th year and then hire them on as formal staff for that PGY 7. Due to logistics, it just kind of fell through. But I can say that in the system and day and age that everything is right now, this is as close of anything as you can actually get to that. Our chief residents have their own service, have their own operating room, have their own operative privileges. And so they do manage everything independently. The reason why we wanted to graduate them was more from a billing standpoint, for them to get experience with that, but also we can charge more money, for that. But again, that was, it just didn't work out.
Thank you. That really answers my question. My main point was for the junior that is inside the OR, there's no need for them to go see a consult, essentially, with the system that isn't.
Yep, exactly. So there's always somebody that's on call that's not in the operating room, and that typically is a physician assistant during the day. I don't know how many we have right now, but I think it's 5 or so physician assistants that help cover the chief services and the acute things during the day. We have had, when I was a chief, we got like 13 consults in one evening. And I can say that certainly overwhelmed us. And I can say that, we have a mechanism that it's, this is the chief, this is the chief junior, this is the person who's on night call, but then you start going down a whole backup list. That's typically very not needed. But I can say that is, in every now and then, that would be a potential possibility. So. Great. I think somebody else was going to chime in before that last question.
Hello. Hi. Oh.
Yep.
Sorry, go ahead. My apologies.
Thank you. Hi, thank you all for your time. I really appreciate answering all of our questions and everything and teaching us more about Mayo. One question I had was about your operative experience, and when do you feel like in residency where you really start to start developing those operative skills in the OR and autonomously and starting to perform, more critical portions of procedures?
That's a good question for the residents. I can just tell you, having gone through our program, I personally felt it was the PGY3 year where you're operating every day, and your skill set is just picking up as it goes along. And I can say that PGY3 year was the year that I really felt like I came in. It was a lot of work, and I can say that every day was a joy, though, because I literally was like, wow, this is just great. I'm learning so much. My skill set's taking off. But obviously, that was well over a decade ago now. So I'd be interested to hear Cody, Megan's, and Lucas's comments.
Yeah, it's certainly a graded scale. So we get our interns from day one in the operative room, and they're learning how to do the exposures, how to do craniotomies, make burr holes, put in EVDs, do closures. And so we get them integrated pretty quick, and their surgical skill set really improves quite a bit that first year. The second year, then they really move into sort of the right hand of the chief. And so they're really responsible for getting cases going, doing a lot of the positioning, doing essentially any exposure or closure for any cranial or spine case, complex or otherwise. And they learn a lot. You feel quite a bit more like a surgeon your second year. You get a lot of autonomy. You're operating, managing a service. And so that I feel like the PGY 2 year is a very critical year for us. You really start to move into your own, become an independent resident. And then as Dave was saying, years 3 and 4 are really years for building that next level, where you're starting to do the critical portion of a lot of cases. Even some of the complex skull-based things, maybe you're taking out a little bit of vestibular schwannoma. Some of our residents are, clipping aneurysms, throwing some knots for bypasses. I did a lot of carotid, so it was suturing a lot of carotid grafts, taking out tumors, both intra and extraaxial, a lot, almost entirely on your own. So those are the years where you really develop quite an autonomous skill set. And the staff really give you a lot of autonomy to grow, but are always there for support, can help build skills. Dave's a really good example. He does a lot of complex pediatric brain tumors, and a classic approach that he uses is the interhemispheric. And the way he sets up the case is so nicely for residents, where you're operating across from each other. And so you do the exposure, and then as you start working and he builds rapport with you, it's sort of a four-handed approach anyways. And as you develop confidence and skill and expertise and you build trust with him, then you get to move in and do more of that, and he's assisting you, and it's able to go back and forth. And so it's a continual skill set. You never really stop learning, of course, but the years 3 and 4 are really critical for becoming a nearly autonomous surgeon for a lot of cases we do.
Yeah, by the time you're done with your 4th year, by the time you hit your 5th, 6th, and 7th year, you're taking chief call. We expect that the residents are going to be mostly independent at that point in time. I remember just a quick story. When I was a PGY 2, I was doing a carotid artery exposure. It was my first one I ever did. And I ended up avulsing the facial vein off the jugular vein. And if you know how much that will bleed, I remember I got so weak in the knees. There's no staff in the room, no chief resident in the room. It's just me and a surgical assistant. That's one of the things we really didn't touch on, is the surgical assistant he like 60 some years old. And he like knew exactly what to do. He's like, okay, let's put our finger on it right here. Let's get some suture up. And he had me sew it. And I remember I had the shakiest hand because I was so nervous. But I oversewed where the facial vein stump had came off. And then all the bleeding stopped. And then, ultimately you got to call the chief into the room. But I remember as a PGY2, this is what I'm doing. The surgical assistants that we have here, most institutions don't have them. These are people that have really just specialized to work with one staff and know exactly how that staff wants to do things every time. And so I think they're a wealth of resource that we have that really also helps teach the residents some of the early steps of just, good surgical technique. And so I think that's really important. When I run my room, my expectation is that by a PGY3, they're able to do pretty much most craniotomies. I build that time to do work. I have 3 jobs. How do you get 3 jobs done? You're constantly multitasking. And so my expectation is that I come help position, but Lucas is doing the craniotomy over the sinus and getting everything set up to be able to do the case, so that when I'm called, it's just, okay, we're getting into the meat and potatoes of the case now. And so I think that's the way that I think most staff kind of expect that. Cody or Megan, anything to add?
Sorry to interject. Dave, was that Dewey or Fratsky in there with you?
That was Dewey. Yeah.
Yeah, I would agree. I think the mentorship model kind of changes when you become comfortable with different things. So for example, I happen to have my rotations ordered in such a way that I started with a lot of the cranial services during my 3rd and 4th years. So I was, on the vascular services with Dr. Lanzino and one of his former partners in the first months of my PGY3 year, and he was having me land the aneurysm clips. But then I saw some of the spine rotations a little bit later. So beginning of 3rd year, would I be comfortable freehanding thoracic pedicle screws? Not quite yet, but by the end of it, yes. So it kind of depends upon when you see different rotations as far as when you feel comfortable with different things. But the important thing is kind of by the end of PGY4 year, we're all essentially at the same place. It just kind of happens in a different order based upon when you see different rotations.
Thank you.
Albert, I see that you had a question. Did you have something? I guess we're starting to get long on time here, short on time, I should say.
Yes, thank you so much. This was a really wonderful presentation. Very beautiful. I'm from Arizona, University of Arizona College of Medicine, Tucson. This is a question for Dr. Daniels. You talked about how one of your jobs is mentoring high school students all the way up to neurosurgery residents. And for me, what's important, like the benefit that I want to get out of a residency is also wanting to give back, because I wouldn't have gotten this far if it wasn't for a mentor or someone out there to get me to this direction. Is there something like informal or formal that you guys have where you outreach to high school students, or just do a talk or something? Because the Mayo Clinic, there's a lot of beautiful history. There's another quote I have from 1938. It's just so much beauty to it, and I feel like you have is there something that we can work with a faculty member that connects with specific high schools, and just to show the beauty of neurosurgery? Because I feel like it's such a it's so hard to get into if you don't, I got lucky. I got connected coming where I came from.
Yeah, that's a good question, and I can say that yes, we do have mechanisms for that. Most of the stuff is kind of sort of informal and kind of who type stuff, but I can say that I have 3 kids that are through the public health system here. People reach out and say, oh, Ethan's dad is so-and-so. And so you start having these opportunities to do things. So I've done probably 4 or 5 cow eye dissections, with classes. I've gone, that's elementary classes. I've gone to middle school and given talks about what it's like to be a neurosurgeon, what it's like to be actually a scientist. I've given talks at the senior high. And so I can say that there are mechanisms to do that, and they are constantly looking for people to be able to do that. And so we do have an actual office that liaisons through them. And so, you know, the Rochester Public Schools has a point person that that connects with me. And I was just fielding an email yesterday, and this is the funny part, is I didn't put 2 and 2 together. Is I got a request for a high school student to mentor him in the fall, and I saw the name, and I didn't recognize the name, and then I finally put 2 and 2 together. It's my daughter's boyfriend. So I don't know if this is a good thing or not, but my daughter's boyfriend is Nate, and the request came in for a Nathan so-and-so, and I don't even think I knew his last name very well, but I finally put 2 and 2 together that I was like, damn it, I would have rejected that one. But anyway, so there are definitely mechanisms to do that. And I can say that that's, I do enjoy that. I can say that if we can get people interested just in science, just in medicine and whatever, I think that that's a great opportunity to kind of be a leader and a mentor into the field. So for sure.
And Dave, I'll interject briefly. There are a few more newer programs that have enrolled residents in particular, but medical students. And so I have a couple medical student mentees here at Mayo and a couple at some other programs, as well as high school students in the area and abroad. And then there's a novel program that Mayo is enrolling now for either high school or undergraduate students from anywhere around the country who don't have formal mentorship either at their school or their institution, who want to get connected. And that can be anything from some basic science research to some outcomes research to just having someone to talk and soundboard ideas off of. So there are a few more discrete programs that are being rolled out as well in the last year or so.
Cody, I'm guessing we're short on time here. We want to wrap it up. And
sure thing. Again, everyone, thanks for coming today and for taking the time. If you have any other questions, please don't hesitate to reach out to any of us or through the program education committee, who's been corresponding with a lot of you.
Let me just say that. So yeah, our email address are in our last name dot first name. So mine is daniels.david@mayo.edu. Please feel free to reach out to me. Please feel free to reach out to any of the residents or anybody. We're all always available. So just feel free if there's any other questions that come up that you want to ask that or didn't want to ask in such a big environment.
I would add our recruitment website is www.mayonsgy.org. My email is not my last name dot first name. It's actually my prior last name dot first name. I got married last year, so there's a contact us website there. If you forget how to spell somebody's last name or something, you can take a peek there and see how to contact us.
All right, that'll conclude this meeting. We'll be giving a talk the same time next week and for every Saturday through the 31st. Next week, I'll be giving a talk on pediatric brain tumors and tumor predisposition syndrome. So if you haven't already, if you want to attend, please RSVP, and we'll see you then.
Thanks, everyone.